Well, thanks for getting up this morning to come here. It sounds like a lot of people were in like Old San Juan last night. There's a social event tonight, so appreciate you getting up early for this. So I'm Adam Elnagar. I'm Senior Medical Director for GYN as well as GU and our hereditary cancers at Natera. Fortunate to have Tom Krivak come join me for this.
Yep, I'm Tom Krivak, GYN oncologist, Pittsburgh. Known Adam for a good while, since you were at Ohio State.
The Ohio State.
The Ohio State, absolutely.
I believe you have somebody from The Ohio State with you as well.
I think Dr. Crafton's in the audience. She's from The Ohio State as well.
Boom.
So.
And so this is the style we expect it to go, is just like easy, we'll talk through it. So a little bit of introduction of just like ctDNA and Natera and what Signatera is, so we kind of all get on the same page. And then let's talk about some of the data and go through some clinical equations. Certainly we can ask each other things, but there'll be microphones around, and then the hope is that this can be more of a discussion. So raise your hands. There's people on either side with a mic to come by and hand it to you. So data slide comes up. We're presenting a case, and you have a question or clarification about it, ask it. That's what we hope to do to address these in real time. So do not save them till the end. And so there's our welcome and introduction. We'll hit some evidence, go through some cases, and then, yeah, hope to have it as interactive as possible. And so I keep reusing this slide even though it stops at 2017 because I think it highlights some really cool features of where we've come with cell-free DNA. So we've known for a really long time that certain conditions increase the amount of cell-free DNA that are in the bloodstream. So when you sampled like pregnant women, there was higher amounts of cell-free DNA than there was in somebody who was non-pregnant. If you had cancer, you had higher amounts of cell-free DNA than you did if you were did not. And so then the question is, well, where is this extra cell-free DNA coming from? It must be because of this additional feature going on that's releasing it. How do we operationalize this? Like, what do we do knowing that there's higher amounts of cell-free DNA? And so as time moved on and technology got better, it got to, hey, maybe we can identify which of this DNA is coming from the baby and which of this DNA is coming from the mom. And if we can do that, we can start to identify mutations that we can help inform. So like Down syndrome and then 22q microdeletions now and really in-depth genetic counseling that can be done before the baby's even born. Well, let's take that one step further and say, okay, well, that's also happening in patients who have cancer. So take out baby, plug in cancer, can we tell the difference between the DNA that's coming from the patient and the DNA coming from the tumor? And so that's what our main focus here is on ctDNA, and so circulating tumor DNA. And so the idea is that you have the tumor there, it's breaking apart, it's releasing DNA into the bloodstream, and you're trying to pick that. And what makes it exciting as a biomarker is the fact that it's non-invasive, so it's very easy to obtain. And it's a real-time dynamic biomarker. So if there's ctDNA there, it's because it's coming from something at that time. The half-life is very, very short. So this isn't like delaying treatment response or takes time to clear. And so it's really coming and going as the disease is. And so it makes a great opportunity for that. And so our main focus is going to be on the residual piece. So focusing on if I test it, is there disease there or not? And then, for Natera, I mentioned the women's health, the oncology piece, but then we've also started to apply the technology to organ health, so which is pretty neat. So the idea that, okay, what if it was the donor organ? We're trying to tell the difference between the donor organ and the recipient patient, because if we see rises in donor DNA, your kidney shouldn't be turning over cells real fast. So if you detect them, it can be an early sign of rejection. And so some good reports coming out of that and kidney and then heart and lung there. And so applications of it. So there's two different scenarios when we talk about like liquid biopsy or liquid MGS or ctDNA. And I think it's important to keep them apart. So we have molecular residual disease testing and then liquid biopsies, which are two totally different things, two totally different validations, tests that needs to be done. They are not one and the same. And so when you talk about liquid biopsy, and I think kind of what was mentioned yesterday with like the low-grade serous and detecting KRAS, that is, I am looking for I know there's cancer there, and I'm looking to see what mutations were. So that's how that test launched, right? It was in lung cancer patients to say, they're hard to biopsy. We biopsy them. There's usually minimal tissue. I know there's cancer there, and I want to know what mutations it has. So I'm going to draw this, and I'm going to sequence it, and I'm going to look for those mutations. So that's a validation test that's done when there is tumor present, that you have the contact to detect those mutations. Go the whole other side. Now you're in a scenario where I don't know if you have cancer. I don't see any cancer. There's no signs of cancer. I've already finished treatment. I want to know if there's something there. And so that requires a whole nother level of validation to say that I can detect these minimal amounts with high sensitivity, that there's something actually persistent there. Did that capture the difference well?
I think it captured it really well, and yeah, I was going to ask you a question once you go to the next slide, because I think this is important as we talk about using MRD, so yeah.
Yeah, and so here's kind of just a little schematic of what we might expect ctDNA to do. Is so at some point there's nothing there, and then a cancer arises and starts to grow, and that ctDNA is going to elevate. And then you do some intervention, and ideally you go into this big drop that goes all the way to zero and then truly clears. But then if you're monitoring it and a recurrence starts to rise, you're going to see that ctDNA come up, clinically apparent disease is there, you do another intervention, and then be able to monitor it throughout the course of surveillance and into metastatic treatments. And so it's at those peaks where I know they have cancer, I can't get enough tissue, I want to know what mutations may be present, if that can help me, liquid NGS. Along that, when you get into monitoring treatment response, so is my treatment working, is the volume of tumor going up and down, or is my cancer coming back, that's MRD.
So, and I think it brings up this really, last year at ASCO, they were talking about, following treatment responses on some clinical trials, Kayla.
Yeah.
And I was sitting in the audience and I'm like thinking, wow, it didn't look so good. And so I call you and it's like, well, Tom, you always have to look, is it tumor informed or tumor uninformed? And I think that's really important, because I think a lot of times when we see a lot of these tests and they talk about ctDNA or MRD, I think the devil's in the details now, that we really have to say, is this tumor informed, tumor uninformed, and how are we moving forward? I don't know what your thoughts are.
This is giving you nightmares of HRD, isn't it?
It's giving me nightmares of HRD, it is, yes.
So there's two totally different ways of doing the test there when you get in it, and they both are validated to look at minimal residual disease. But one's tumor naive, where you say, hey, here's my sometimes my ovary panel that I'm going to use to run against it. Here's my bladder panel or colorectal panel that I'm going to use. So I'm looking for these specific mutations, and if it's there, I'm going to say it's positive. Tumor informed, I think when it's coming to some of these clinical trials, more and more, the value of doing it as a tumor-informed assay is continuing to make itself kind of clear. So many of them are tumor-informed now. And then for that, there's two ways of doing it. And I think what's plagued like GYN cancers in the past of like, we can't detect peritoneal disease, there's too much heterogeneity, we can't do it, was because those tumor-informed assays were, I'm going to sequence it for ovarian genes, and then I'll track the ones that were detected. So I'm sequenced it, it had a PTEN mutation, so I'm going to track PTEN longitudinally. Well, high specificity, I mean, you identified a PTEN. If you found the PTEN mutation, yes, they did have cancer, or it was coming back. The problem was it didn't have PTEN. Well, because that tumor-informed test was only at this time, so then treatment pressure, heterogeneity, things like that, it gets lost. So the other way, and that's our segue into kind of how Signatera works, is it's a tumor-informed assay, but it's truly personalized to that. So there is not a an ovarian test or a bladder test. It's truly all tests, all tumor types are getting the same test because it's personalized to that patient's tumor. So we take the tumor, we sequence it, and we're looking for single nucleotide variants that we think are going to be unique to that tumor. So we're not looking at specific genes or favoring particular genes, because we want the ones that are going to be the more benign clonal passenger mutations. So if we told you what variants were, they would mean nothing. And then we sequence the patient's germline, which is another important step, because we want to filter out any sort of SNPs that the patient may have, or what's CHIP mutations, clonal hematopoiesis of indeterminate potential. I had no idea what that was until I got here.
Look, clonal hematopoiesis is still,
It's a thing.
HRD confusing at times. Yeah. You hear it in like clonal hematopoiesis, and how do we filter that out? And again, I think sometimes we get confused in this, and we just need to have the basic stuff so we can make sure that we order the best test. But yeah.
So and the thing is that makes those CHIP mutations hard is like P53. That's a great sign of ovarian cancer, right? We should just be able to track P53. Well, the problem is you can get these CHIP mutations in it, where there's like a non-pathogenic mutation within P53, and you get more likely to have these CHIPs as you get older. So when we start talking about 67-year-old women that were tracking P53, there's multiple spots where you can get this CHIP mutation, and you'll have that problem. So another reason of sequencing the tumor, filtering out the germline, making sure you're tracking unique ones, and then you can use that over time. You look like you had something.
No, I think it's perfect. I mean, I think it's personalized medicine. We're trying to make it's specific to the tumor. I think that's the big difference between tumor uninformed and tumor informed. And, when we look at data moving forward and we look at clinical trials, I think we have to see if it's tumor informed and how they're looking at it, because you've evolved your test over the last few years and new tests are coming on board. And so it's going to be, how do we want to look at this, and what are the pros and cons of each test?
Yeah, and they're all very different. And so, we're going to try to focus more on the clinical level than totally nerd out on the science. But there are additional features to it, even when it comes down to like, how are we going to do that sequencing? And so there's multiplex PCR, which is how our test is designed. And what that allows for is we're saying these are the variants, specific variants that we're tracking, and we're going to be able to just read over and over and over again for that particular variant, and allows us to go really deep and targeted. So essentially, you're reading it over 350,000 times trying to pick up the signal that variant is there. When you start to do hybrid capture, now you're sequencing across the whole thing with multiple variants that you're looking for, so you're not honed down as much. And so what that means is you have to spend a lot of that PCR time running over a large amount, and so you can't get as deep, and that's where you start to get more errors introduced to it. Then the other piece that's now also being introduced as part of the assay is this idea of phased variants. And so what that is when you're looking for like single nucleotide variants, there's always a chance that a variant that you're detecting isn't a true mutation, because you don't have the other base pair to like match up with it. And so, but if you find out that there's those variants in close proximity to each other, the likelihood that you're looking for 3 variants in close proximity to each other's happening by chance is almost 0. And so by adding, I'm looking for variants that are together in a close amount, you take out some of the noise and further improve that level of detection and lower the error rate. Okay, so I'll do this last thing, and then you're really on the spot.
I mean, I think it was perfect how you explained all that, because, again, I think, tumor informed versus tumor uninformed, what makes the test better than other tests. And again, I think, just like we were talking about, like low-grade serous, it may not shed as much. And I think many of us in the audience that do surgery, I think we understand that, caring for patients is challenging, and that, tumor shedding is going to be, probably different at different points in their unfortunate cancer progress. Because, I can still remember like operating on folks who are, hospice palliative care, and it's more of a palliative surgery, and seeing the tumor at front being kind of fresh and bloody, and then at some of these other surgeries, it's extremely fibrotic in the tumor microenvironment, and I always think these tumors probably aren't shedding as much into the bloodstream as up front. And so to me, it kind of makes sense, and as you show us how your detection is going to improve, it's really going to help us feel confident with the tumor assay. So.
Yeah, and your comment about the shedding is definitely a key feature of how which it will affect the assay performance. So, high shedding tumors like muscle invasive bladder cancer, like colorectal cancer, and like many GYNs, because you know how heavily mutated they are, a lower sensitivity assay, which is like the exome assay, which is a lot of our data, performs really, really well. As you move into like renal cancer or lower grade cancers or hormone positive breasts that are lower shedders, you start to see significant benefits as you add these additional features onto the assay. But so the one exciting thing readout was last year, so this is end of the year, IMvigor11 readout. So this is in muscle invasive bladder cancer, so bear with me. It's the point. There's a point that I'm getting to. So the study was truly designed around ctDNA to say, if you're ctDNA positive, I'm going to do treat versus no treat. And then if you're ctDNA negative, we'll observe all those patients. And then they did what's called kind of extending the adjuvant window, meaning I'll serially test you while you're negative. And if you become positive in that first year, we'll put you up into the randomization arm. And the thing is when this study launched, the question was, and what we still kind of hear is, okay, so I've seen all these KM curves, positives do bad, negatives do better, so what? You haven't shown me that if I do something on that positive patient that I'll actually improve survival. Well, yeah, you do improve survival by treating patients that are at high risk of an event. And then when you go and you look at the negative patients, so this study wasn't built around a non-inferiority design to say treatment, no treatment in negative patients. But because they were serially testing those patients for conversion to positive, you can see if during that first year of serial testing, there were no overall survival events. And really, there was only about like 8 DFS events out of 360 patients during that serial testing timeframe. And so, you're going to do a non-inferiority study against 96% DFS in negative patients?
You can't do that.
Yeah. So, I mean, it didn't answer that non-inferiority, but it gives you a really strong signal that probably you're not going to improve that in negative patients by giving them a treatment. Like, what's the magnitude of benefit you're looking for? But certainly, DFS and OS improvement by treating positive patients. So, kind of first of its kind study there.
And it's important you did the trial because if you go back to the inclusion criteria, they didn't have evidence of the disease. So it wasn't like they had surgery and somebody left in positive nodes. It wasn't like they were leaving cancer. It's like they were saying these patients are in remission, but they have positive ctDNA, so they're not. Yeah. And so should we treat or not treat? And again, I don't treat bladder cancer, but I remember being at the presentation and, people were very, very impressed. I mean, I don't treat bladder cancer, but being at ESMO, I wanted to see what the data showed and everything, and it was very impressive to see patients or clinicians saying this is important because, again, do we just let the patients recur and wait and treat, or do we treat up front? And this is what it said that they should treat up front. So I think it's disappointed that we didn't do the trial in GYN, because we're all GYN oncologists, but to me, it was nice to see collecting prospective data for patients with cancer and showing that treatment interventions work earlier on. So, yeah.
We'll get there.
We'll get there.
That's what I'm working on.
Absolutely.
And so we'll apply some of this data into practice. I'll keep going on this.
Okay.
Take it away.
Yeah. So I think there are a lot of experienced people in the room. I've seen when I saw people walk in that, how we care for patients is really evolving. And so as me and Adam were talking, we were like, we want to make sure that folks, if they hear something or if they want to add their experience, to make sure they do that, because it's really not a lecture, it's more of an interactive session. But again, as we think about what do we want to do for these patients, and you look at some of the data, it's pretty impressive in that, you look at your neoadjuvant chemotherapy, your upfront debulking folks, and then looking at second and third line, and how are we going to use ctDNA to help kind of change what we do. And you can see on the slide here, it says neoadjuvant chemotherapy, frontline chemotherapy, and if you have a positive, ctDNA, that, you have a poor outcome, which I think we all know makes sense because we go back to our second look days where we gave chemotherapy, did surgery, and, if you had a positive second look, patients didn't do well. So we know that, but we don't have to put them through a surgery now to try to find some of this. And then looking at second and third line treatments and looking at when patients progress, to me, looking at their ctDNA, you can see there that when patients become positive, that obviously their PFS decreases. So I look at this data and say that we can use it in upfront as well as we're monitoring. And like we've talked about, as we go through the data, we saw yesterday Rosella presented, we saw B96 presented, we have mirvetuximab. So we now have very effective therapies for patients who are platinum resistant. So the earlier that we can detect some of these changes, we should probably initiate some of these other therapies. So to me, I think this kind of shows that it can be a longitudinal type of test as we can use it up front as well as in the recurrent setting to kind of help manage our patients to try to give us information as we're caring for those folks. And the bottom line is that we all know that CA125 is important, but it's definitely not perfect. Is ctDNA perfect? No, it's not perfect because nothing's perfect, but it does give us more information, and probably looking at the data gives us more accurate information. Go to next slide. And so, looking at, longitudinal versus point testing, and, this study was done, and my colleagues across the street, McGee, was involved with this. I think it was Dr. Boyson that was one of the authors. But looking at a time point to look at if you are positive at the completion of surgery, you can see that the chance of you progressing was very, very high. And so they had one component looking at any time point, or at one time point, and then they had a component at looking at longitudinal. And again, you can see if you are ctDNA negative, you can see those 15 patients. The patients did very, very well versus the patients who turned positive, which again makes sense. And that's what ovarian cancer is. It's a very chemosensitive disease. It shrinks, it goes away, but it's a very virulent disease. When we take patients off treatment, it wants to recur. And I think, again, when we look at these positive patients that turn positive, you have to think about this study was done 7-8 years ago. Again, we've had additional trials. We've had more data come about that we can go ahead and make better interventions. We have better medications that we can offer our patients to try to help and prolong their PFS as well as improvement in overall survival. Because again, 3 trials showing improvement in overall survival on platinum-resistant ovarian cancer in the last few years is pretty doggone impressive. And now we have a test that may help gauge when we're having these patients turn resistant so we can go ahead and do interventions. But again, if you look at it up front, showing time point after surgery, if you're ctDNA positive, you're going to do poorly, which makes sense. That's what we saw with second looks. But again, now we have better interventions. So if we know that information, we can use chemotherapy, PARP inhibition, changing treatments, and we do have cases that can kind of highlight that.
Yeah, I always, if you're looking at the curve on the right, the single time point one, I do usually try to point out the fact that is somewhat of a mixed stage. So that is not to say test your stage 3 high-grade serous one time and there only one event's happening. There is a mix of stage there. But across, regardless of the stage, that prognostic factor holds up. But as you can imagine, a negative in a stage 4 patient is not a negative in a stage 1. Those are prognostic in themselves as well.
Very good point. And again, I think the point, we need to start thinking about this longitudinally. When do we going to start? How are we going to make our interventions? Because as we care for patients, I always think when I'm taking care of somebody in the clinic, what are the factors that I'm looking at? I'm looking at, radiographic imaging, CA125 blood tests, looking at physical examination findings, looking at their symptoms. All those are going to play into effect as we kind of longitudinally follow these patients to try to make decisions with regards to their treatment. And so you can see here again, it outperforms CA125. And I think, I don't see how that can be a surprise because I think most of us who care for patients will see the CA125 and again, knowing that the second look data, you had chemotherapy, surgery, your normal CA125, normal CAT scan, and if we take those patients for second look surgery up front, 60% were going to be positive that we said were in remission. Mm-hmm. So again, finding a test that's going to improve on CA125 as well as improve longitudinally, that's what you're seeing here. And again, from the data from Ho and Boyson and the multi-institutional trial that had like 55 patients, you saw that it improved detecting a recurrence 9 months early, which I think a lot of us would say, does it really matter? But I also think too, just like we were talking about, 3 trials. If somebody's recurs early, we can make interventions. We have numerous effective therapies that we can say, why should I give this patient, carbotaxol for 3 more cycles when we know that it's not working? So I think the earlier we know, we do have treatments that are effective that we can intervene, which is very different than 15 to 20 years ago. And so I think as we look at our technology to be able to detect differences, our interventions have changed greatly as well. So it's kind of a win-win situation. Whereas before, if we detected it early, it's like, what can we do? There's really nothing we could do.
No, that's a great point. When I look at the specificity line there, I think about what I think a lot of us would do in practice is, they finished adjuvant therapy. They clinically have responded, but their CA-125 is still elevated. And you're kind of in that, well, am I really just going to stop? Or, maybe they're HRD and I'll switch to PARP and maybe that'll normalize it. Or do I give them, 3 more cycles and then monitor this? Yeah. When you look at this and kind of say, well, even the normalized patients are a coin flip, and then 20% of these elevated are still not going to have an event. It's kind of hard to start to think of how that could really inform me. But I think your point about having a treatment is really important. So I should point it out in Vigor 11. The preceding study for that was in Vigor 10, where it was all comers, atezo versus observation. 800 patient international phase 3 study, completely negative for benefit, even when they looked at it by different biomarkers. So atezo versus obs in patients who were PD-L1 high and TMB high, and showed no benefit for it. And then when we looked at it with ctDNA, it was able to separate it. If you were ctDNA negative, no benefit to the addition of treatment, positive, significant benefit with the addition of treatment, and that prompted the one I just pointed out. But one of the things that I think highlights your point really well is you have to have an effective drug. So when we went back and looked at the positive patients, yes, across all positive patients, treatment was better than watching them. But if you looked at the patients that were TMB low or PD-L1 negative, well, those are predictive biomarkers for response to immunotherapy.
Yep.
Or predictive biomarkers for immunotherapy. So if you were ctDNA positive, all those patients were having events. They were all having events, and were having events quickly. But adding atezo didn't help them. And so it goes to kind of what you're saying is great. We've identified this patient as being ctDNA positive. Let's give them an ineffective therapy. Shockingly, it didn't improve their outcomes. So you got to have a therapy, which now we have 3 new approvals. So.
We do, and I unfortunately would continue patients on PARP as their CA-125 was rising, and as I practice, that's probably the wrong thing to do because we're probably just inducing more resistance. So again, having treatments to change, I think, are really, really important. So following the ctDNA, I think, in conjunction with CA-125 is important. I love this study here. This is Dr. Jazari's study. I would encourage everybody, if you haven't read this study on second looks and ctDNA, to really pull it. And I've read it about 4 or 5 times, and every time I read it, I take home something different. Not to criticize them, they did laparoscopy, and if you look, I think on average they had 11 or 12 biopsies. If I do a second look, I'm generally going to get probably twice as many, 25 to 30 or 40. And I think when you look at second look data that was done back in the late 90s, you really want to do that. So I think when we look at this, I'm not criticizing their surgery, but I guess you can say I am, but I'm not. But the bottom line is that when you have positive ctDNA and a negative second look, it made me wonder, they're doing laparoscopy, and if you would have done a laparotomy, you may have received more biopsies and potentially found some of the microscopic disease. But to me, when you look at the ctDNA positivity and the second look positivity, you can see that the patients who were ctDNA negative, the patients who had second looks that were negative, did very, very well. And again, the patients who were positive didn't. And if we can go to the next slide, and you can see the top line there, second look or the bottom curve, second look positive, ctDNA positive. Those patients did the worst, and then the top, second look negative, ctDNA negative, those patients did the best. So, in my mind, when I saw MRD testing coming, I thought to myself, again, 60% of patients up front, we're going to say they're in remission, they're not. PARP inhibition, bevacizumab, in my opinion, worked for maintenance therapy because it's treatment maintenance, but this was going to replace and actually help us with second looks, and it's going to replace second looks. This study did have differences between patients who were ctDNA positive, second look positive, and again, none of this is perfect because shedding is going to be different, second look surgery is going to be different, but the bottom line is that it's a predictive test. Second looks are predictive, but if we go to the next slide, you can see that they're putting patients on trial. So when we had a positive second look in year 2000, we gave somebody Doxil or Gemzar, things that probably weren't so effective. Now, if they have a positive second look in Anderson, where Amir's doing the study, now we're putting people on trial. So you're catching people early on, you're putting them on trial to see if these effective medications are now are helping these patients that have, residual disease, again, microscopic residual. And to me, this is where we need to be. We need to figure out who's going to have positive disease. PARP inhibition, bevacizumab work, at least I think bevacizumab works. I'm sure many don't believe me, but I think bevacizumab works, and so I'm a big fan of maintenance because I think it's treatment maintenance. But this is going to help tailor these things. And if one of these trials come up positive, ctDNA is going to be able to potentially replace second looks because we don't really do second looks. So I think this trial was very important because it's trying to compare second look surgery to ctDNA. I wish it was more concordant, and I think as the test gets better, as second looks get better. But the bottom line is we detect these folks, we do have interventions that we can do. And so take them off their treatment and go ahead and put them on a trial or put them on some effective medications.
Yeah, and I think one of the things is when we look at what happened within these discordant cases is, you need two things for CTA to be positive. You need it to be there, and you need the tumor to be active. So if you're on treatment and it's effective therapy and it's suppressing it or limiting it to the more indolent, slow-growing disease, they're going to have clearance and have a better outcome. And I think that's what's highlighted there in the top two, where they were second look positive, ctDNA positive. Of course, they did very poorly, and if you were negative, that was the best group. But look at the patients that were second look positive and ctDNA negative. And I think that's what killed second look as the surrogate endpoint, right? Because in the early 90s, back when I was in high school, they did these studies where they said, I'm going to give you this therapy, and then I'm going to look at second look, and if I've caused more negative second looks with drug A than I did in drug B, then drug A must be more effective. Well, it was kind of missing it. Or if you were second look positive, I'll do this. But I think, treating inactive, slower growing, or a tumor that's already responded really well to upfront therapy, it's going to be hard to say you're second look positive, CTA negative, let me give you this therapy, improve on a 2-year median PFS.
But you're absolutely right. If you look at your ctDNA negatives, they did the best, no doubt about it. And so those are the patients that may not need as aggressive treatment. And, again, you look at these, it's 44, 50 patients on this trial. And if you look at the number of authors on this paper, it's about 55. And so, I always make a joke, you want have more patients than authors when you publish. But what it shows is these studies are tremendously difficult to do, and these folks did an awesome job at Anderson to get this study done. These are very, very hard trials to design, to execute, and to enroll. And, I just commend, Giseri and the folks at Anderson, and it was a multi-institutional trial, just not getting it done, but, putting patients on trial that were positive. So, I kind of chuckled when I counted up the authors, but it goes to show you how complex it is and difficult it is to get these studies done, so they did an outstanding job. I think we pretty much, I think most of us, that have cared for patients know that C125 is poor with RECIST, and it shows that, as we cared for folks, we'd follow the C125, get scans. It shows why we have to see these patients. It shows why we have to follow these things serially because, again, C125 is a good marker, but we all know it's not perfect. We all know that we can see patients who may have radiographic evidence of disease or a positive PET scan have a normal C125, or things are rising for other measures, and the patients are doing just fine. So it was nice for folks to look at PARP and say that it's not going to match RECIST criteria, but I think most of us who are in the clinic seeing patients with ovarian cancer, recurrent ovarian cancer, treating patients, pretty much know this, that, caring for patients isn't just one test. It's going to be numerous things, blood tests, scans, physical exam, as well as their symptoms.
And then there was another study that came out at the same time in the British Oncology Journal, looked back at Calypso, the Doxil study, and used GCIG criteria to monitor for progression. And it was really nice to see the two of them come out about the same time, because of course here's the one for PARP, where we're monitoring in a surveillance setting, and then on that one they looked at using CA-125 and using that criteria, and showed really that 2/3 of the women with progressive disease who had normal CA-125 by that criteria. And so, whether it's in the platinum setting or in the PARP setting here.
Yeah. No, I think we all know that it's not a perfect test, and this is adding to that. And so this is, again, another small study, but very, very important, presented at SGO, but looking at ctDNA positivity when you're starting on PARP. And so what I like about this is, again, as you look at the positive 7 and ctDNA negative 5, that correlates with what you'd see with most likely second look. So I kind of like that's like 58% positive. So to me, that kind of makes sense. But again, showing that when you're ctDNA negative, you're going to do poor. If you're ctDNA positive, you're not going to do as well. So something that we can look at, make a decision, and again, potentially change to a different therapy, not continue to give these patients PARP-induced, more resistant clones and things like that. So to me, I think it's a great time to have a test with all these other changes that we can have effective therapies kind of get initiated.
So of the patients that had a baseline, it is low. It does get bigger as we get into like kind of the all-comers longitudinal one. But this was launched as unfortunately, there's no good biobank, and none of the PARP studies collected a biobank that had the longitudinal time points to really capture this feature. Right. And so it was a study to really say, hey, if they walked in clinic on a PARP inhibitor or getting ready to start one, I'll just start testing now. Because the idea of are we detecting progression or identifying people without progression kind of applies whenever we start. So that was the idea. But when the ones that had it here, and you called out like positives do worse than negative, what are the thoughts that positive and negative was right at the end of carbotaxol and then going on to the PARP? So we're switching to an effective therapy, but like we're not helping a whole group of patients.
Well, I would have thought we were helping these patients more, but obviously we're not. And again, we'll have to know if they're BRCA mutated or not BRCA mutated, because we may have different, HRD positive versus HRD negative. I think we need to look at that, and obviously need more data, and I think all of us would say that's what we need. But the bottom line is that if it's positive, they're not going to do as well. So if you're following those folks, I would say we need to look at possible early intervention, or at least consider it. And again, some people may say we don't want to do that because we want them to feel good and have a good quality of life, but at least you know that this patient's at high risk for recurrence and early progression. So, to me, I think it's a piece of information that everybody in this room would probably digest differently and counsel their patients similarly, but come up with different plans.
Well, and I'll ask you this. So you had taught me, this was a conversation we had a while back, was about like when you looked at some of these subgroups of the patients on these PARP studies, the shorter the time you were on PARP, the shorter the time you did when you had your platinum-sensitive recurrence. And so, those who were only on it for, they made it over that 6-month mark, but they weren't the 2-year person.
Yeah.
And they went back on platinum, and those were often platinum-resistant recurrences in shorter time. Well, this is the flip of that.
Yeah.
You finished platinum therapy and you're still positive. Like, does it look like synergistic either way? Like platinum 2 PARP or PARP 2 platinum?
I think they're synergistic in that you're probably platinum resistant.
No. Challenging you.
But and again, I think we've changed the whole platinum resistant paradigm by having PARPs and bevacizumab, and is at 6 months the same as at 6 to 12? So I do think that we're changing that, and again, that would kind of factor into the counseling with respect to what to do. I'm sure we get some of these tests and say they're positive, but I'm not going to do anything. I'm going to watch and see if it clears. If it doesn't clear, you have the longitudinal data that says if you don't clear, you do poorly, which is, here. And patients are going to clear, not clear, as we'll see in some of the cases, and the folks that have been following patients for a long period of time can see that. So, to me, you want to be negative. If you're not, you're positive. It makes us start thinking about treatment plans if they don't clear what we need to do. So I think it gives us information to try to help, prepare ourselves, prepare our patients for changes that may be coming. And again, yeah, this is the one this is part of the study that if you cleared, you could still become positive, but if you're still positive, you did poorly. So I think the underlying theme is ctDNA negative. We should feel, I don't want to say comfortable, but we should feel better, and patients are going to do well. If patients are positive and then persistently positive, that's a bad sign.
Yeah, and I like that, again, the way the study was set up kind of limits some of the numbers in the group, but really it's capturing that dynamics piece is where I think there's a lot of the value in the longitudinal testing to say, okay, they are negative or they cleared, but is this durable? Or the idea of like, how deep is this clearance, so to be? Are we just below the level of detection, or have we truly like eradicated it? And so when we start talking about people who had that early test, the second one, or the test within 3 months and the 6 months, like really exciting because like each additional negative test, the less and less you are to flip to positive, and then that kind of this matches it up with the CA-125 perfectly.
And I think it makes sense because I think we all know that CA-125 isn't perfect. And I think, to me, when I hear, I don't know what I'm going to do with this test, but I still order a CA-125, I'm kind of like, well, if you're still going to order a CA-125, that can be false negative, false positive. Why wouldn't you get the ctDNA, the Signatera? Because, to me, it's all pieces of information that may help us kind of make informed decisions for our patients, moving forward. But again, I think what we've seen is, and I think we all know this, is that C125 is not perfect. And again, go ahead. Oh, sure.
Adam, Tom,
Ready.
Great presentation. So about 30 years ago, there was a study in the UK, and I'm blanking on the author's name, a medical oncologist, where they randomized patients to either have CA-125 monitoring or not. And I'm sure you're familiar with that study, particularly Tom. You and I have gray hair, so we were around.
I was applying to medical school.
Yeah. At the end of this day, though, the patients who were getting the CA-125 monitoring had detection of recurrence sooner over the lifespan of their remaining time. They had more chemotherapy, but at the end of the day, there was no difference in survival. So clearly, we have more therapies to offer. Now, we didn't have PARP inhibitors, IO, BEV, et cetera. But the reality still remains that most patients, essentially all who still have persistent disease after first-line therapy, are going to die of their disease, and they all have their different trajectories, some faster, some slower. But it seems to me that the main value here might be in improving PFS or OS, by some months, even if it's 3 to 6 months. So that's the sort of end game that I'm looking at is, now that we have newer therapies, can we improve OS? We're not going to cure more people, I don't think. We might help people live longer with more selective therapies. And so how do you balance that against the cost of monitoring someone? I missed the beginning, but I don't know if you say anything about, like, what's the cost of monitoring somebody with Signatera for 2-3 years, and how much you might gain, and how we balance that as we sort of consider value-based care.
Dr. Burchak, you always bring up really, really good and important points. So the Rustin paper, I'd be the first to say that I was at McGee when we interpreted the Rustin paper, and there was a lot of disagreement. Kristen Zorn, tremendously bright physician, really started to limit C125s. I kind of took the approach that when I read the paper, that it was a paper that limited kind of treatments because it was from the UK, and I kind of said, if you're only going to treat your patients with 2 or 3 additional treatments, it probably doesn't matter, monitoring C125. And so I've always thought it was hard to compare that paper to a US population where most patients come in, and anybody who works with me knows I'm just not good at hospice talks. I'm not good at knowing when to say when. I wish we had a test that would say you shouldn't treat patients anymore. So, to me, we're kind of taught to treat. And I think that when I looked at the Rustin paper, I'm like, well, I'm going to treat folks so they're going to live longer, and that CM125 does matter, that CM125 doesn't matter if you're just going to limit the number of therapies. So that was my interpretation of that paper. But I completely agree. There are many folks that say that it's quality of life, and that patients on the Rustin paper had more anxiety over their CM125s, and you're right, received more chemotherapy and actually had a poor quality of life. So I think you're right. I got the gray hair, and back then I didn't really adopt that, but folks did. And again, I think if anybody who works with me, they'd say, I try to focus on quality of life, but to me, knowing when to say when is the hardest thing to do with this job, and so looking at how to treat folks and when to make changes is that. I think the cost, we can get into this later, and I think we have it in a couple other slides. I'm employed by Highmark, an insurance company that owns our health system, and we're actually thinking, can we use this test to actually decrease the frequency of scans? So are we going to shift costs and end up saving by, decreasing other interventions? And I do understand the SGO guidelines saying that, use scans as clinically indicated. You don't have to do that. But there are plenty of people that are getting scans every 6 months, throughout this. And, that's not right. But I know that our system, as we think about it, we may be able to limit scans. So I think it's going to be hard to monitor the cost, but there's no doubt about it. It's more expensive to obtain a ctDNA versus a C125. But you bring up very good points. There's absolutely no doubt about that. And I think those are all, I'd imagine everybody in this room has their way that they counsel patients, treat patients. And I'm sure that within everybody's practice, they say this person's going to operate on everybody and give everybody chemo, and this person's going to, be more judicious on who they operate and how they do things, and those kind of things. So you bring up really good points.
Yeah, to the cost piece, we do these cost effectiveness studies all the time. To get life years gains, the drugs would need to cost this much to make it cost effective, and the majority of the times those studies aren't. And so for a number of these, for the bladder or colorectal cancer studies where we truly have kind of the data to say treat, don't treat, is to start to do some of that cost effectiveness and look at, hey, even if you took out reduction, patient assistance, things like that, here's the cost of the test versus a more of what is it currently of treating 80% of patients. So if we avoided those costs of drugs, those pharmacy costs, those infusion times, those toxicities, those patient visits, and we cut all those out and did this, it's a healthcare savings in tens of millions range. And then when you talk about augmenting scans, it does really become a cost-effective proposition. So now where we have some of these more definitive studies where we can look at that value proposition in 1,000 patients, those are starting to come out. But I think conflict of interest, I'll put that over. But to the question about effective therapies, Taxol wasn't approved in Europe till 2003. That study started in 1996. So to the question of you have to have effective therapies to intervene early, I think is a very important point. I think it was 60-70% of patients got platinum for their third line therapy. So, very different world today. And if I was just to tie what's happening in some other tumor types, is getting into these kind of questions of, well, what do I do if you're ctDNA positive? So this InVigor study design had I'll serially test you and then treat you when you flip positive. And if they looked at the positive treatment, no treatment at the single time point, or positive, no positive at the subsequent test, that DFS OS curves looked exactly the same. And we have a breast study where you're serially testing on endocrine therapy, and if you become positive on that, you go to an AI versus a CD46 inhibitor versus staying on it. And so kind of escalation on positivity and maintenance. So those studies and some of the other tumor types are certainly ongoing to really dig into that question.
Yeah, and the cost effectiveness, Highmark wants us to be cost effective with this, and that's coming from the insurance branch, working in with us and the clinicians to make sure that we look at this, and they pretty much, I don't want to say they've said this, but the inference is if it's not cost effective, we're not going to support it. So they want us to do some real world analysis and look at it. So I think your point is we have to be very judicious because healthcare is getting very expensive. So yeah.
Well, and I hadn't thought about the CT scan issue. We have patients who aren't even on trials that are getting every 3 months. So,
And patients
yeah.
are living longer, and so I actually think CT scans are expensive as well as, damaging to the kidneys, and so our patients are living longer. I mean, again, I remember when I was a fellow, 98 to 2002, most of the patients I operate on passed away by then. Now, patients are doing so well, so I think we just have to be very judicious with what we're doing, because patients are living longer.
Yeah.
Okay.
Yeah, so to wrap up the ovary piece is just to highlight a talk that Emily O'Brien at UAB is going to be giving later today, which is looking at a neoadjuvant ovarian cancer biobank and having ctDNA at the baseline, end of neoadjuvant, after interval, and then end of therapy. So exciting data. Be there. Okay, so quick dive into some patient case here, and so I'll have to stand outside the tumor. So 65-year-old woman with stage 3 high-grade serous, so has an XLAP with tumor debulking there, and you can see that mutational profile. And here we're capturing, they're CTA positive after that primary therapy, and then you're seeing the clearance occur there, and they're switched to maintenance therapy. And then ctDNA starts to rise, and that's going to trigger the scan showing that correlating mixed response, and then put back on therapy. And so, as you think about this patient having the clearance and being able to counsel, and then using it to help prompt imaging, kind of what are your thoughts there?
It was complementary, and I think it shows kind of like what we see with some of our ovarian cancer patients, in that it's a virulent disease, responds to chemotherapy. They had a nice response on maintenance Bev, started to progress, used the Arila, protocol with, paclitaxel and Bev, had a good response. And again, this is what I would do, because I'm an Uber Bev user. May not be cost effective, but, I would have treated this patient exactly like this, put them on Bev, see what happens, and then, if they're potentially going to tick back up at a later time and institute another therapy at that time. But I think this is kind of what we see. Yeah. And so,
do you see Mito 16 when you look at that, Bev after Bev there?
Yeah, Bev after Bev's good. And again, yeah, I still think when we were talking about when I was a fellow prolonging the platinum-free interval with topotecan, and we really showed that didn't work out very well. So again, we have more treatments, better treatments now, and so maybe doing some of these interventions are going to help our patients. So yeah. So uterine cancer, yeah.
Uterine cancer.
So again, how are we going to use this test? Looking at, who we're going to tailor adjuvant chemoradiation to, who we're going to use it for surveillance, and how we're going to initiate therapy. There's plenty of studies looking at, small studies looking at positive versus negative. And again, as we look at our slides, we'll talk about, are we going to change therapy? We're going to add therapy. We're going to de-escalate therapy. But I think when you look at it, you look at, blood tests, CT scans. Obviously, the ctDNA, you can see by the hazard ratios on the slide, are very significant at showing who's going to recur, who's going to progress early, so who we may need to tailor therapy to. I think endometrial cancer is a very heterogeneous disease, and I think that, how we look at some of our studies and what we've done well with our studies and what we've done poorly, this would be an adjuvant to try to help us figure out who we're going to treat, who we're not going to treat.
Yeah. And I think this slide is just kind of highlighting that what we've talked about in terms of the approach to uterine surveillance. There's no, okay, sure, high-grade histology, sometimes CA-125, but there's really no biomarker, and we're really using as clinically indicated to guide that.
And again, I think, it's like, if somebody said to me, what was one of the biggest hindrances to me using this test for endometrial cancer patients, it was thinking about it. And, Dr. Crafton in our practice, she was an early adopter. And again, I think that when we start looking at this, you can look at, P53, extensive LVSI, and then if somebody's got a positive ctDNA, probably going to want to give them chemotherapy. Some people may say P53 is not enough, but if you have a positive ctDNA and you have a high-risk histology, so again, it's are you going to order a test and act on it? I think that's what needs to be thought of. And as you start to order it, as you start to think about it, you say, okay, if it's positive, I'm going to do this, it's negative, I'm going to do that, then that's an important piece of information to get. And I don't want to say I was a slow adopter, but I was kind of skeptical and a little bit slow. But to me, as I started seeing patients thinking about this really makes a lot of a sense how I'm going to kind of divide it up.
And I like how you worded that in terms of, I have these two options. This is an extra piece of information to give me confidence about picking what would be those two options.
Yeah.
Which one's better?
And then again, looking at who's positive and who's negative, you can see the underlying theme is if you're positive, we probably need to intervene with those folks. If you're negative, it's a nice piece of information. Giving that to the patient probably will improve their quality of life, saying, hey, everything's good, but you can see if you're positive, you're going to recur early, and are we going to change therapy, are we going to add therapies, those kind of things for those patients with stage 1 endometrial cancer.
Yeah, and to the scan question, this is kind of capturing that, right? Like, scans were happening on those serial negative patients, and none of them were having an event, so all their scans were also negative versus all the positives. It was only the positive patients having an event, so, could really help spare those.
Mm-hmm. So, I completely agree, right? You want to do this, you want to act on it, you definitely want to get scans. If it's positive, maybe you can avoid doing all those scans if it's negative, using it that way. But what I struggle with right now is, when do you jump in? Even in that slide of the ovarian cancer patient, right, the ctDNA went up, but you didn't actually intervene until the scans became positive. Mm-hmm. And so there's a couple of issues. Is that still the right thing to do? And then also, how do you counsel patients once the ctDNA is positive and you're saying, well, let's just repeat it, let's just do the scan, but we're still not going to act until the scan's positive?
I think every patient's different. Some patients may have a positive and slightly elevated, and they want to have a change of therapy. And again, it's tough because you have to talk with folks. We may run out of treatments. We may be acting too quickly. But you're going to have patients who want treatment, and you're going to have other patients who will be like, I feel good. I don't really want anything. And so it's information that I think is going to be applied to each different patient.
Right, but that's not actually how we're supposed to practice, right? We're supposed to practice based on the evidence. It says that acting earlier will actually improve overall survival and quality of life.
Completely agree, but when you have new technologies, we have to figure it out somehow, and it's going to take time to figure that out. Clearly in medicine, our technology is advancing faster than we can do the trials to actually understand how to intervene with everything. And then, again, I was a slow adopter, so do you say, I'm going to wait for all the evidence, or do you kind of want to start to apply and say, I'm going to make these decisions to these patients in a different way? You're completely correct, and in a perfect world, where we would have plenty of patients, plenty of trials, and we can get these things done in 6 to 12 months, that would be perfect.
And I do think that's easier to do in an academic setting or a large institution setting, and harder to do in the community.
Completely
agree. It's a real mix. And also, then, do you lose the opportunity for that patient to participate in an upcoming clinical trial?
You may. Yeah, I can tell you this right now.
I think those are just struggles. I'm not saying anything. It is hard, and you do want to act as soon as you see positive, and then you want to act with all of these 3 new trials in the ovarian that show that it does improve overall survival. But will it still, if we act earlier, or will it even work better, which is what I'm optimistic for and hoping for?
Yeah, I called a patient platinum resistant based off ctDNA and CA125 and tried to put them on clinical trial later, even after they had MRD, and they got DQ'd because you didn't have rhesus CT scan progression. So you're absolutely correct, and I was really bummed because the decisions I made with that patient, unfortunately, did not allow her to go on clinical trial. And so, to me, it's a learning process. But you're absolutely correct, just like Dr. Burchak's correct with a lot of this. And I was saying that 3 or 4 years ago. But as I'm looking at this and thinking, wow, if I have this, I'm going to make different decisions. And so that's why I've started to adopt it. Mm-hmm. But all very good points. Okay. And this was, again, longitudinally looking at, different histologic subgroups, which I think is important because we're trying to figure out, endometrial cancer is just very heterogeneous. Who do we treat, who do we not treat? And then really, I think the next slide.
Yeah. And this is also just kind of capturing those questions about, we can't detect GYN cancers. These are all stage 1 patients post-operatively and then following them longitudinally. So this idea, MMR proficients are low shedders, so ctDNA is not going to work on them. The p53 wild types aren't as heavily mutated. These are grade 1 tumors, NSNBPs, ctDNA doesn't work on them because they're a low shedder. Well, it's not the question. It's a technology question, and obviously we're getting there now.
Yeah. And we look at the PORTEC trials, the GOG trials, how are we going to say who gets what? it really hasn't panned out. And that's why we're doing the molecular subgroups, looking at clinical. And so, again, it's an additive test. And you're right, we have to figure out how we want to do it. And everybody in this room, I think, is here because we want to figure out how to do it better.
I snuck this one in on you, so I'll take it. I could have let you struggle for a while. So this is just looking at, so we took a cohort of, these are all truly stage 1 patients immediately post-op and prior to any adjuvant therapy. And this is just looking at physician-directed decisions. So they use, traditional clinical pathologic risk factors to try to determine how they were going to make their treatment decisions. And you can see here, no significant difference in it. Here's the slide you saw before.
And again, I think it shows, looking at patients who are positive versus negative, it really does give us a predictive, patients are going to do poor. We really need to consider some type of intervention for these folks, or changing the intervention that we're doing.
Yeah.
There's no doubt about it. And again, serial CT, I shouldn't say there's no doubt about it, but to me, looking at serially as well as one time point is going to help us give information to help kind of decide how we want to change therapy, de-escalate therapy possibly as well. So to me, I think it's a nice adjuvant in this setting test.
Yeah. And then, here's a case with a stage 1 high intermediate risk, where post-operatively the patient was ctDNA negative, did undergo observation, but then was seen to become positive, prompting that imaging. And so using it to kind of, again, tailor when is it time to image these patients to try to identify it. Because, they ended up getting chemo IO, so probably not a localized recurrence, but catching before symptomatic.
Yeah. Okay.
And then
monitoring treatment here, with Floor. This was a nice poster. We can go next slide. Looking at, platinum-resistant ovarian cancer, recurrent endometrial cancer, patients with high risk, patients who are going to progress, just basing treatments not just off imaging, but off imaging as well as the ctDNA being positive, clearing it to be negative, knowing that patients who cleared did live longer than patients who never cleared. To me, I think this is a high-risk group that we know are generally going to do poorly, but potentially helping us try to figure out when to start treatment, maybe when to give patients a treatment break. But the bottom line is we're trying to gather data on clearance, who's going to clear, who's not going to clear, and how effective are these therapies. And then again, monitoring endometrial as well as platinum-resistant ovarian cancer. We had patients on this trial. We didn't do ctDNA because we were at West Penn, and these were some folks that were treated at numerous institutions. But you can see if you were positive, it almost reminds me of if you're HPV positive, you're at high risk for developing cervical cancer. If you stay persistently ctDNA positive, you're just going to have a poor outcome as well versus clearing the disease at times when you respond to treatment. Kind of makes sense. If you clear disease, if you respond, you may respond to other treatments, so you're going to have an improved PFS as well as a possible OS.
And here's a patient example that did allow for some, and these are all real patients that we were able to kind of gather from, well, maybe a couple of people in here. So a 64-year-old woman with advanced grade 3 endometrioid, and so got a staging surgery, went on to chemo IO, and then was transferred, then began the dostarlimab maintenance piece, and had negative imaging at the time of going on to that, but then progressed to being ctDNA positive, which triggered that reflex imaging. And so at that imaging study, had localized disease just to the pelvis, or more specifically to the interior, the vaginal cuff, and so was able to go radiation.
Yeah, I mean, I think radiation therapy is perfect for this patient. Stayed on dostarlimab, the Escapol effect, maybe re-educated the immune system to help, further on. But again, showing that, it's an additive to your physical exam, adding in the CT scan, and having effective therapies to be able to help, render the patient in remission again. I do think, having a negative ctDNA, some people may say that's false reassurance, but to me, I think, having a negative CT scan, all that, I mean, none of these tests are perfect, but having all these additive things will kind of, I don't know, make patients feel better, as well as, again, kind of help us strategize how we're going to treat patients, how we're going to follow them, how we make schedule scans. Again, I'm saying may a lot because we're all going to do it similar but different based upon, your comfort level with the test and other things going on with the patients.
Yeah, and I think this highlights the case of being able to identify it where at a time point when it could affect therapy, metastatic versus a localized recurrence, where radiation is a possibility. You said tie in other tumor types. So MD Anderson has a program called Intercept for their colorectal cancer patients. And so after surgery, kind of more positive patients are really trending to go towards treatment, negative patients trending towards being observed. But in the patients are pretty much put into this registry where we're going to serially test ctDNA and then use it to really guide imaging. And so what they saw was when a patient flipped to positive and they scanned them, about 50% of patients had disease at that time. Of those that were negative initially, it prompted, a further workup. So the indeterminate imaging that you were like, well, let me do a dedicated chest, let me get a PET, let me get a targeted liver MRI. And so that resolved another half of those. So you ended up with about 15% that were truly a molecular only recurrence, and then they had kind of trials that they could go into from there. They don't have the survival data there yet to say, okay, this is, by using this paradigm, how did we benefit or what do we do? But clearly decreased scans. They have a really nice surrogate that it probably did make a survival difference, because for patients with oligometastatic disease that can undergo metastasis-directed therapy, those are still curable situations in those patients. 80% of the patients had disease isolated to one organ that could undergo a metastasis-directed therapy, whether it was surgery, SBRT, microwave ablation, something like that. And so what it's saying is hey, of all these recurrences, if we could identify them when they were still a targeted intervention, it's probably a good surrogate that we'll see the survival outcomes to that. And so when I think about this endometrial one, kind of that same idea, if we could identify it there.
Yeah, if we're not looking, we're not going to find it. I think we all know that. If we're not.
And here's another case that I think is one that kind of highlights how it can help with discordant imaging or suspicious one. So this is a patient that was recurrent endometrial cancer that was getting pembrolizumab. Well, on it, starting to get toxicity from it. They're thinking about stopping it. Soon after stopping, develops some abdominal symptoms and has this 8-centimeter lymphadenopathy. And so the ctDNA is negative, so kind of prompted what's happening here. Repeated the test, ctDNA was still negative, and the patient's becoming symptomatic, more symptomatic, brings them into the hospital, and finds out hey, this was all pancreatitis. And so, skipped what would have been the normal biopsies, skipped to from jumping to back to a treatment, but really going, these are discordant, let me give it some time to work this up, and pancreatitis was captured there. And maybe it's only a couple, so maybe we'll skim through this. And
yeah, so I think cervical cancer, I think, looking at who may benefit, who may not. Again, consolidation, chemo maintenance, surveillance. I always think that we have potentially a PET scan that's, what do we do? And so I do think that when we look at how we can use for cervical cancer, you recur, we start you on immuno. If you have a bunch of tests that are negative, 3 negatives, potentially de-escalating care, especially patients who may be experiencing side effects, who've been on it for a year and a half to 2. I've had a couple patients, very well educated, that as soon as their first one was negative, they wanted to stop, and I'm like, please, let's stay on this regimen, let's get a couple more negatives. None of these things are perfect. And then I've also had patients that have had a questionable positive PET. Do we do surgery? And the ctDNA is negative, which gives some reassurance that we don't need to intervene at this time. So again, I think as we look at our individual patients, you can say, okay, if it shows this, it may do this. Understanding that none of these tests are perfect. I'm not saying that ctDNA negative is perfect, ctDNA positive is perfect. None of these things are perfect. We all know that. So it's additive to what we're doing, and it may help you decide, I'm going to delay this or not do this for that patient. Yeah. And then again, our radiation oncologist at West Penn's thinking we need to push our PET scans out and actually start doing ctDNA for these patients earlier to try to help look at scans and do less scanning. because again, I don't want to say that we're being driven to lower costs, but to me, we do have a lot of these PET scans that at times are nebulous. Is it positive? It's negative. Have to get another scan, and that this would be a surrogate to kind of help add in with a PET scan or potentially decrease the number of scans for our patients. But again, if you have a positive ctDNA, that's probably something we're going to need to intervene, whether it's radiation therapy, additional chemotherapy, continue on immunotherapy, surgery, or something of that sort, I think is important.
I think of all that, like Grigsby data where it was like patients that had a partial metabolic response on PET at 3 months, like 40% of them went on to clear. So how do you identify which camp those patients may fall into before they have the progression or symptomatic? I see it fitting in there.
And again, this is looking at events with ctDNA negative versus positive, and that's been the theme. If you have a positive test, it's probably something that you really need to follow these patients closely, especially if they don't clear that you may have a negative event for those patients.
Yeah, and so we'll give a quick shout out there to Dr. Holloway and his fellow here.
Yep.
So also later this afternoon will be the oral presentation. So we showed that poster that got best poster at Winter SGO last year. It was only in the teens. Now it's about 60 patients pulled together with some other institutions looking at surveillance in cervical cancer. So that'll be later today. Then, I don't know.
Again,
this is kind of capturing some interventions, helping to solve indeterminate imaging. But let's wrap it up with the utility things.
So, looking at other tumors, obviously very, very important. MRD testing in GYN cancer is increasing. And, I'm trying to encourage our division to try to all get on a similar cadence so we can kind of discuss these in tumor boards and try to come up with protocols to help kind of answer some of these questions. Because, it's not MRD in a vacuum. It's MRD. If it's positive, what are your interventions? And you can see by coming to SGO, coming to ASCO, ESMO, we're having all these new interventions that are very effective that we may be able to apply to our patients. And so, I'm not a very cultured fellow. I'm a sports guy and I work. So I think we're on the 5-yard line, and we got 95 yards to go with this. So I'd encourage everybody to hop on the team and, take a couple carries, grind out 2 or 3 yards here and there to get us to that end zone. But it's going to take us all together to get this done, to get a full understanding of how we're going to use this in gynecologic oncology. And hats off to Dr. Solani and her team. You can see now it's incorporated into the SGO guidelines. Consider it to order it for patients with ovarian, endometrial, as well as cervical cancer. So it's worked its way into the guidelines. So I think that has said something that this test is here. It has affected patient outcomes. Studies are small. We need to do bigger studies. We all need to kind of figure out how it's going to work. It is not a perfect test. I had a patient who was like 44 years young, had CH. I did her surgery, frozen section was negative. I left her ovaries in and she has a grade 1 endometrial cancer. I didn't want to take her back, take her ovaries out, or take lymph nodes. And she's very bright. She's like, hey, let's do the ctDNA test. So I ordered it and it was positive. So I was terrified. But she was much more mature than me. She said, let's just wait and see if it clears. And it did. So she's had 2 more negatives. So I've not done any interventions. And then I had a patient who had ovarian cancer 6 years out, clear cell cancer, CA125 is normal, had a CAT scan that said she had recurrent disease, followed up with a PET scan 2 months later that said she had recurrent disease. ctDNA was negative. So I took her to surgery because everything was kind of confusing. ctDNA was negative. Said, let's see what we find. Took her to surgery, and about 30 biopsies, everything was negative. And so to me, that kind of justified that, I cannot use CT scans or PET scans to follow this patient. I'm going to have to use either a C125 or most likely a ctDNA. So these things are all, I don't want to say confusing, but patient care can be very confusing at times with different things weighing in. And so this is just a test to potentially help give you information to make a decision.
Yeah, and I think you said it well, and I think how they incorporated it into kind of that SGO statement was helpful in select cases. So, you didn't describe a scenario where you were like, here's my dogmatic algorithm, I do this versus this, but here's a discordance. How can this help me resolve it? I know Dr. Holloway's done a couple webinars and just describes, hey, I'm trying to counsel a patient towards treatment. She doesn't want to do it, so we know it could be beneficial. So let's look at this test. Let's use it to help with counseling. Let's help with timing of monitoring or resolving ambiguous imaging. And so I think we're working really hard at generating the evidence, and I like your statement. We all need to, working together, we want to get to that definitive point, but right now, I think people are seeing, getting utility out of it.
It's gaining traction. I look at the GOG wanting to do the de-escalation trial of 12 months apart versus 24 months apart. This needs to be integrated into that. We need to know who clears one, that do the patients who have a positive need to be treated for 24 months, the negative for 12. Mm-hmm. We really need to start looking at that because, Dr. Burchuk brought up a really good point, cost effectiveness. If you can save, a year of a $12,000 treatment, you just saved $250,000 for the health system based off of a $1,500 test that ended up costing you $12,000. So to me, I think de-escalation is very, very important, not just for cost, but for patients, a side effect profile. Again, decreased scan frequency is going to help with radiation exposure, contrast exposure to the kidneys for our patients. To me, I think all these questions are very, very important. It's going to get answered just in time as we all participate together for this. And
so now on NCTN is looking at the question in the higher intermediate patients that keeps recurring coming up. How do I direct therapy when given there's all this evidence that says there's no survival benefit? I remember from my tumor boards where it was if I said I want to observe this patient, I was bombarded with why that was the wrong answer and I should radiate. So being a smart fellow, I was like, next week, treat this patient. And then I was bombarded with why that was a bad idea and you should observe them. So had ctDNA been there, I might have been like, hey, if we could use this and identify this might help tip us one way or the other. And so this study is trying to help answer that question. So patients that are ctDNA negative, to be a truly de-escalation, non-inferiority study to look at vaginal brachy versus observation.
And this is very important. I mean, Natera has done a great job. They did their bladder trial. We're going to move into endometrial, so we're trying to answer the questions prospective because that's what we all want. We want prospective data. It's going to take a lot of time, and I think we do a great job of spending other people's money because a trial like this is probably going to be $200 million, $250 million. These trials are expensive. So, to me, I'm glad that they're doing this because I do think prospective data, I think every trial's got pluses and minuses, and probably some people would say, I don't really like this. I would do this. But again, we have to start somewhere. And so we're doing the retrospective, we're getting prospective, now we're doing a prospective trial. So I think we're moving in the right direction. Again, I was a slow adopter. Dr. Crafton was a quick adopter. And, talking with her and having our tumor boards and seeing how things were done made me to start to rapidly, include this in part of the, the surveillance, part of the decision-making for our patients.
Yeah. Thanks, man.
Any questions or thoughts, comments? Yeah.
You could see a world where ctDNA would impact, like when you added a combination therapy, like for instance, if you had a patient on MRD DNA starting to increase, but their scans were negative or showed stable disease, would you add Bev in that situation?
Yeah. The question was seeing a world where somebody's on an active regimen becomes positive and then do like an escalation, so from like a singlet to a double or double to a triplet.
Yeah, I can see that. I mean, Lempem, we use that quite a bit in endometrial. If you start somebody on Keytruda and then they start to progress or have ctDNA go up, then add Lenvima in. I think it's a great, because again, how these medications potentiate each other. Some people may disagree with that and say if they're progressing on MIRV, don't do MIRV-Bev, you just have to change therapies. But again, I think, say MIRV-Bev is just as right as saying that you're going to change treatments. I mean, I think what you just described is the art of medicine. The science is understanding the data. The art of medicine is taking it individually and applying it in that way. So people are going to do that similarly, but different. But I would do what you just said. Yeah.
I also wonder about switching on positivity instead of recurrence, if that actually may lead to it. Because when you become positive, it's kind of like this molecular recurrence. And so if you're saying, hey, they're becoming positive because there's an escape mechanism, and instead of waiting till I have radiographic, so that clone's fully developed, if I can hit that escape mechanism before there's clinical disease, maybe I can derive more benefit because I didn't let that expand.
Yeah, no, you're absolutely right. If somebody has ctDNA recurrence and you continue to treat them with carbotaxol and they're not clearing, all you're doing is
Breeding resistance.
giving them toxicity and not really treating the disease. And again, it's evolving. I mean, we're going to have next generation tests and more sensitive and stuff, so it's going to be important. But I think all those questions are going to be answered when I'm retired.
Rob Holloway, thanks for the presentation. I wanted to make a comment about what do you do with a positive and all the anxiety around that, and how do you talk to your patient. I think one of the first things is understand the disease, what your options are. What are you going to do with anytime you do a test, what are you going to do if it's positive, what are you going to do if it's negative? Think that out before you order it. But first thing I would say is when you've got negative scanning, plan an early repeat on your ctDNA to see the trend. For instance, if you've got someone on Bev maintenance and they turn positive, but you do your next one 6 or 8 weeks later and it's positive but essentially flat, you may be suppressing. And you got to ask yourself, can I do any better than that? Should I just keep them on Bev and keep watching? As opposed to somebody who triples, then you're going to repeat imaging, and start maneuvering on your next plan. One caution I would give is on immunotherapy. I've seen patients on immunotherapy maintenance who are sequentially rising but have negative scans, and your reflex is to say, well, I've seen 3 rises. I've got to, I'm imaging you. Maybe we should consider a switch to something else. But I've had patients, and I've talked to them, and I said, well, you're tolerating this well. I don't see anything on scan. Let's just continue to watch this. And I actually have a few patients who've risen over 6 months and then gone back down to near 0. And they've never really cleared their DNA, but they've been on Lem-Pem, for instance, for maybe 2 to 3 years. So there's something about immunotherapy and suppression and the microimmune environment that's going on. I would recommend not making a rapid change off therapy and continue. I have concerns about de-escalation until we have prospective protocols because of that instance. You may be suppressive therapy and turning down cell turnover. Potentially, if you stop too early, it's going to reignite, the stem cells. So be careful on immunotherapy, making quick changes. And I do follow radiographic. Thank you.
Excellent points.
One quick question. Instead of using CT for follow-up, why not use MRI? PET MRI, CT. The problem is that many of these patients have a lot of recurrence and you are giving a lot of radiation. I know probably the quality of the images are different, but MRI are excellent. Thank you. And instead of using imaging, why not to use clinical judgment?
Well, I always use clinical judgment. I always do that. So clinical judgment is going to change based upon the information that I have. MRIs are hard, at least at our institution. That's going to be a much longer wait than a CT scan. And the claustrophobia, I hate ordering MRIs because it seems like everybody hates MRI tests because claustrophobia. And so to get an MRI efficiently and not have the patient say negative things about me on the internet, because Krivak's running an MRI and I'm stressed and
It's more expensive too, right?
Yeah. So I think again, if you're comfortable ordering MRIs, then that's what you do. If you're comfortable doing CT scans, then that's what you do. If you're comfortable doing PET scans, that's what you do. And then this is in addition to that, and you may change your cadence of how you do those tests. I'm not saying you have to do this, or this, but how I look at it is I'm using this at how I may change the cadence of how I order some of those tests. And I'm hopeful to get less tests. But you're right, an MRI is going to be much more tolerated on the kidneys and radiation, but I would have to say if I get complaints about MRI versus CT scan, the complaints about MRI are much higher, much higher. But clinical judgment is above everything. There's no doubt about it. Good points.
All right.
Awesome. Thanks, Adam. This was great.
Yeah, man.
All right. Thanks, everybody.